Hello guys! Welcome to the HLA channel. Today I have something different for you. When I was in the college, in the university here in Brazil, we used to have in the laboratory a journal club where weekly some of the students or professors, they presented a paper related to their works, to their research project. It was something that helped us a lot, especially the students, where we were discovering everything, and I took that habit with me even today. I try to read some papers as much as I can to be updated with everything that the HLA community is talking about. And today I have a different paper. It is not a clinical paper or a basic research paper. It is like a review paper. It is difficult to present to you, but I found this paper when I was searching for applets. This is something difficult for me, and then I found this paper and I would like to share with you. The paper was published on the International Journal of Immunogenetics in 2020 by Dr. Hla Eplets. I don't know if I said her name correctly. I'm sorry if not. And her colleagues, especially the first author is William Lemire. And the title of the paper is Matchmaker. Matchmaker, make me a match. Funny title, no? Opportunities and challenges in optimizing compatibility of HLA Eplets in transplantation. Currently, the assessment of donors and candidates' compatibility relies on acceptable mismatch strategies, with an acceptable mismatch defined by the presence of performed donor-specific antibodies, the DSA we know much well. Anti-HLA antibodies are produced in response to previous exposure to HLA through blood transfusions, pregnancy, and transplantation. While the verification of preformed antibodies relied historically on cell-dependent crossmatches, nowadays donor-recipient compatibility is assessed by virtual crossmatch or flow cytometry crossmatch. Complement-dependent cytotoxicity (CDC) assays inform the highest risk of immune-mediated injuries. On the other hand, flow cytometry and virtual crossmatches are considered more sensitive assays, allowing detection of lower titer and non-complement binding DSA that pose a lower immune risk than that identified by positive CDC. In contrast to flow cytometry and CDC, virtual crossmatches rely on knowledge of donor HLA genotype and are deemed positive when single antigen bead assays confirm presence of DSA. The implementation of virtual crossmatch is based on the verification of PRA, the panel-reactive antibodies. To determine the PRA score, transplant candidates undergo routine screening by single antigen bead assays. This is often referred to as a calculated PRA, which considers the entire donors population rather than a select panel of representative donors, as in the case of cell-based PRA. Anti-HLA antibody screening in candidates and the calculation of PRA have improved the capability to predict cellular crossmatch results and, consequently, have resulted in a decreased likelihood of transplantation in the presence of unacceptable HLA mismatches, rejection, and graft failure. Despite the advantages of CPRA and the virtual crossmatch, some limitations must be noted. First, CPRA may be highly dependent on the timing and context of the testing performed. Anti-HLA antibodies may wax and wane over time, resulting in fluctuation repertoire of unacceptable mismatches and consequently also resulting in different proportion of potentially compatible donors from the pool. Acknowledging this, transplant centers may use the cumulative CPRA, which considers anti-HLA antibodies that have been detected over the entire course of pre-transplant screening. The cumulative CPRA is also dependent on the detection of antibodies, which is itself dependent on laboratory practices. This dependency makes standardization of SAB assays analysis challenging. Factors including serum handling, choice of MFE threshold to determine the presence of anti-HLA antibody, and the specific test kit used are critical to the final interpretation of the assay. Further, complication in the interpretation of SAB assays is their sensitivity to issues intrinsic to the serum sample, such as inhibitory substances, referred to as the prozone effect. Thus, the virtual crossmatch is vulnerable to misclassification of candidates' risk of recall responses due to immune memory, which may yield diverse repertoire of unacceptable mismatches. While CPRA is informed by existing and/or historic anti-HLA antibodies, it fails to capture the risk of developing new, previously unobserved antibodies against donor HLA. When detected for the first time post-transplant, these antibodies are referred to as de novo DSAs. Epitope analysis could overcome some of the limitation of CPRA as a determinant of historic, current, and potentially de novo DSA. The focus of epitope analysis is on the specific polymorphic regions on the HLA that can bind to antibodies. Some epitopes may be restricted to target a specific HLA protein, but others are shared between different proteins, with each allele coding for HLA protein and the unique combination of epitopes associated with it. Epitopes that are common to different HLA molecules explain how certain anti-HLA antibodies may demonstrate cross-reactivity to proteins coded by different alleles. Structural analysis of crystallized HLA complexes allowed the identification of accessible amino acids on HLA molecules that can be bound by antibodies. Based on this principle, Tuskenoi and colleagues developed HLA Matchmaker, a structurally based matching program. Each HLA antigen was viewed as a string of applets, or short sequences involving polymorphic amino acid residues in antibody accessible positions. A comparison between the donor's repertoire of applets with that of the recipients allows for the estimation of the cumulative mismatch load, or the sum of applet mismatches by HLA locus and or class. To document the evolving appreciation of eplets and their validation as epitopes through the antibody verification, the HLA epitope registry was established. The HLA epitope registry captures lists of alleles associated with each eplet, provides data on whether a putative eplet has associated antibody reactivity, indicating that it may be an immunologically recognized epitope, and outlines the validation method used for antibody testing. Patients with a PRA higher than 6% are considered sensitized, and patients with PRA higher than 85% are considered highly sensitized. Highly sensitized patients are less likely to access transplantation and be matched with a compatible donor. To increase access to transplantation for the above disadvantaged population, Eurotransplant developed the Acceptable Mismatch program that allowed mismatches in HLA-A or HLA-B when DSA were not present against the donor HLA proteins as determined by cell-based cross-matching. To further expand the donor pool, mismatches were also allowed at other HLA loci, while simultaneously ensuring a negative cross-match result. Practically, in addition to transplantation occurring on the rare occasions when HLA allele-compatible donors is identified, this strategy also enables organ allocation to highly sensitized patients despite presence of mismatched HLA alleles, provided that the associated repertoire of eplets is compatible. As more allele combinations are considered compatible, this inevitably helps expand the donor pool. Indeed, it has been shown that matching at the eplet levels rather than the antigen level allows for a higher probability of identifying compatible donors for highly sensitized patients. In addition to increased access to transplantation in highly sensitized patients, the assessment of eplet compatibility may offer advantages across transplant candidates, whether sensitized or not. The advantage of this strategy can be attributed to its ability to explain and help avoid not only preformed antibodies, but also de novo DSA. When perfect matching is not possible to achieve, assessing incompatibility at the level of HLA eplets can be used for risk stratification. Indeed, eplet mismatch load has been linked to the development of de novo DSA, T-cell mediated rejection, transplant glomerulopathy, and graft failure. Genotyping at all 11 loci of HLA genes is necessary to determine the candidate's and donor's eplet repertoire. HLA genotyping methods can be classified into two broad categories: probe-based methods and sequence-based methods. Probe-based methods include SSP and SSO typing. These two techniques offer low-cost, rapid turnaround, yet both methods have the disadvantage of providing low or at best intermediate resolution genotyping with residual ambiguity of allele assignment. In contrast, in sequence-based genotyping, the specific allele is determined by resolving the exact genomic sequence of alleles. Sanger sequencing is often referred to as SBT, that enables high-resolution typing of HLA alleles. Next generation sequencing, NGS, has reduced the infrequent inaccuracies observed in SBT, but is associated with higher implementation costs, which can be a barrier to its integration in HLA typing laboratories. Moreover, NGS is not immune to residual ambiguities with occasional allele dropouts. The processing time required by SBT and NGS methods makes them less useful for deceased donor genotyping. With advances in genotyping technologies, it is expected that sequencing-based typing could be implemented with shorter turnaround times, or that an epitope-based typing strategy could be developed. Importantly, a novel approach has been designed using long-read nanopore sequencing. While the long reads minimize inaccuracies introduced when assembling short sequencing reads, this technique still suffers from some shortcomings in read analysis and interpretation. Should these deficiencies be resolved, the turnaround time of long-read nanopore sequencing would allow the rapid generation of high-resolution typing in a matter of hours, as required in the deceased donor transplant context. By the way, there is a pioneer high-resolution kit using nanopore technologies for HLA typing that could be used in the deceased donor transplant, but I don't want to influence you. The paper explains very well how is the role of T helper cell epitopes immunogenicity. Let's take a look.
The role of T helper cell epitopes in immunogenicity. CD4 positive T helper cells are important for the development of a productive antibody response. After recognition by the B cell receptor, HLA can be internalized and degraded into peptides. These peptides may then be presented on self-HLA class II on B cells. Presentation of self, or non-self, allo HLA-derived peptides by recipients class II HLA may determine whether a specific applet mismatch will lead to an antibody response, and whether ADSA, isotype switch, would occur from IgM to IgG.
The paper cites this other paper from Kramer et al. That also explains the role of T helper cell epitopes in immunogenicity, with a simple but elegant image.
The B cell receptor recognizes an epitope on a foreign HLA molecule. This leads to internalization of the target antigen, which is then degraded into peptides. Some of these peptides bind to the HLA class II molecules on the B cell, and the foreign, non-self, peptides are recognized by CD4 positive T cells. This leads to the activation of the T cells, associated with the production of immunoregulatory molecules. These molecules trigger a class switch of the antibodies produced.
Algorithms have been developed to consider predicted indirectly recognizable HLA epitopes binding to HLA class II. These represent antigens from donor HLA class I that can bind to the donor's class II HLA and can lead to T helper cell responses. PIRT2 is associated with an increased risk of DSA development, rejection, and graft loss. To better understand how PIRT works, you can access their YouTube channel, which contains many explanation videos and webinars, including a webinar with Massimo Mangiola. By the way, you can access and subscribe to the HLA channel on YouTube as well. In conclusion, applet matching represents an important refinement of HLA compatibility assessment in organ transplantation, with a potential to mitigate immune-mediated injuries and prolong graft survival. This review brought to note some of the challenges on path to ensuring applet compatibility at the time of organ allocation, including the current impracticality of timely high-resolution donor 11 loci HLA typing, the fact that repertoire antibody verified applets in HLA Matchmaker is in flux, lack of data on the differential risk associated with particular applet mismatches informed by their immunogenicity and antigenicity, and a sufficiently diverse donor pool to facilitate the optimization of HLA compatibility. This review also highlighted opportunities to overcome some of the challenges toward the considerations of applet compatibility, including evolving rapid high-resolution genotyping techniques, standardization of antibody verification efforts, and automation of applet repertoire and mismatch determination from genotyping data. I hope you could get important information, important theories, important statements from this paper, from this video. And if you liked these kind of videos presenting, sharing with you a paper, please make a comment here and make your suggestion for a new paper to be shared here on the channel. Okay, thank you for watching. See you next time. Bye bye.